All right, welcome everybody. Welcome to our first UVA Medical Center hour of the fall season. Very exciting. Thanks to those of you who have come in person. Thanks to those of you who are with us on Zoom today. We have a really exciting fall semester planned and no better way to kick it off with today's lecture in partnership with the Brodie Education Committee here at UVA. Before I introduce our moderator, I'm Justin Mutter. This is a program of the Center for Health Humanities and Ethics here at UVA. I want to just mention some of the basics of how today's session will run, since we have a live audience and we have a Zoom audience. When it comes time for the Q&A after our speaker has finished speaking, for our live audience friends, please feel free to raise your hand. We can take questions with microphones. For those of you who are on Zoom, please feel free to put your questions in the Q&A part of your Zoom screen, and we will field those questions via our Q&A discussion at that time. For everyone, please know that you can get continuing education credit for your participation. Please just follow instructions that you'll see on the slides. For those of you on Zoom and those of you who are here in person, there's a handout that you can follow the instructions after today's event. Now it's my pleasure to introduce today's moderator, Dr. Evan Heald. Dr. Heald is Associate Professor of Medicine, a longtime leader, as many of us here at UVA know, in both undergraduate and graduate medical education. He's practiced general internal medicine at University Medical Associates, and he advocates extensively for the social mission of the health professions education, really across the continuum of trainees' clinical experiences. He is director of the Brodie Medical Education Committee, and Dr. Heald will introduce today's distinguished speaker. So welcome, Evan.
Thanks so much, Justin. First, I want to say that the Ann L. Brodie Medical Education Fund Committee is named for and endowed by a grateful patient who so valued her longitudinal relationship with her trusted primary care doctor that she willed her estate to medical education. And she instructed Dr. Corbett to ensure that future generations of doctors would have the heart and skills to care for patients as he had cared for her. Dr. Corbett focused our work not just on clinical skills and communication skills, but also on teaching advocacy skills and teaching on how to work within the systems that we practice inside of. We train professionals, and our profession has tremendous power for good. And this power comes from a social contract, which has granted us autonomy to regulate in the best interests of the patients that we serve. The contract depends on trust. And we wonder, does medicine still have the trust? What happens to trust when legislatures and insurers and systems and programs impose their own regulations on professionals? Dr. Barry Egener is our 2023 Brodie Medical Education Scholar. He's visiting us this week from Oregon, where he practiced and taught internal medicine, and where he's currently developing a well-being program for a health system in Southern Oregon called Asante Health. Dr. Egener has a longstanding interest in communication and professionalism. He's the past president of the Academy for Communication in Healthcare. He served on the Institute for Communication in Healthcare and the Foundation for Medical Excellence. He was a director in the American Board of Internal Medicine, and he co-developed and published the concept of organizational professionalism. So I'm eager to hear Dr. Egener's thoughts on organizational professionalism and the social contract. Dr. Egener.
Well, thank you, Justin. Thank you, Evan, for the introduction. Thank you for the warm welcome just now. I really appreciate it. And thank you for the Brodie Committee to invite me to what has been a really terrific visit so far. I'd like to speak with you about the concept of organizational professionalism and its potential to strengthen the social contract Dr. Heald just mentioned the social contract. It's basically the idea that medicine deserves some degree of autonomy, self-regulation, in return for acting in the best interest of society. I don't know why it just occurred to me this morning for the first time, but the social contract is the first contract that I've ever participated in that's not written down. And so there are no words to litigate. So what does it depend on? Well, Dr. Heald just mentioned trust, and I think that's what it depends on. And I have been thinking a lot about trust lately because people have been pointing to the fragility of another concept, American democracy, because of a lack of trust in government structures. But I'm going to concentrate on what we can control. So first, does society trust the medical profession? I'd like to speak a little bit about threats to the medical profession, both from inside the profession and outside. I think it'll be useful to talk a little bit about the roots of professionalism and how it evolved. And then we'll talk about organizational professionalism as a restorative to trust. And I want to acknowledge that there are some pieces that professionalism cannot solve. So first, it's interesting that physicians and the public at large have comparable levels of trust in the healthcare system. So roughly 2/3 of both physicians and the public have some level of trust in the system. Roughly 1/5 are neutral on it, and roughly 1/5 have some level of distrust. And this is from a study by the American Board of Internal Medicine done in 2021 through the National Outcomes Research Center in Chicago. It also turns out that doctors and patients trust clinicians more than other parts of the healthcare system. So looking at physicians first, 94% of physicians have trust in the physicians within their practice. 85% have trust in doctors outside their practice, which is identical to public's trust in physicians, and both have high levels of trust in nurses. But when you look below this line, when you look at those who provide indirect care to patients, trust diminishes. So for physicians, 80% or 4/5 trust healthcare organization staff, roughly 3/4 trust hospital or healthcare facility, and 2/3 trust the healthcare organization leaders and executives. Looking at the public, it drops to 72% confidence in hospitals, 64% healthcare system as a whole. About half of the public has trust in government healthcare agencies, and only 1/3 have trust in pharmaceutical companies and health insurance companies. When you look at all professions inside of medicine and outside of medicine, then what you find is that nurses are actually the most trusted profession, and doctors come close second. Then you see a number of other professions, and at the very bottom, you see that the least trusted profession is members of Congress, which worries me, even below car salesmen. This was a study conducted by Forbes in 2022 through Statista. So this is the kind of event that was occurring in 2014 that made Dr. Walt McDonald and me think about a new construct for professionalism and that it might be useful. So in 2014, the New York Times described an event about a 37-year-old man who had a 3-hour surgery for herniated discs. He received a bill from the hospital that was $56,000, and he expected that. He received a bill of $4,300 from the anesthesiologist, also expected. The bill of $133,000 from the orthopedist in negotiation with his insurance company was reduced to $6,200, which he was responsible for. But he also received a bill for $117,000 from an assistant surgeon that he didn't know. And that was a surprise. And it was a surprise that was not covered by his health insurance because his assistant surgeon was not on his plan. So first, I just want to draw attention to the numbers on the screen. It would be nice to work for a day or two and then to be able to retire for the rest of the year. And as many of you know, since 2014, Congress has passed the No Surprise Act, which makes this kind of an unexpected bill illegal. Currently, in these kinds of situations, the network contract price will apply. And there's an appeal process for the insurance company. But I want to come back to this regulatory point in the future because professionalism will not solve all the problems of the medical profession. But here's a much more recent example. There's a drug that came out a couple of years ago called Egener. It was the first in a series of drugs to treat Alzheimer's disease through a totally new mechanism, first new mechanism in decades. And basically what it does is it scours amyloid from the brain. It's anti-amyloid antibodies. And the FDA had an expert panel from the outside who recommended that they not approve this drug because the data was not sufficient to show that it was effective. Nevertheless, the FDA did approve this drug. And the problem with that is that depending on who received the drug, whether it was all patients with Alzheimer's disease or only those with early Alzheimer's disease, the cost could be enormous and break Medicare's budget. In fact, in 2022, the Medicare Part B premiums went up 14.5%, partly in anticipation of covering the cost of this particular drug. Because it's administered intravenously in doctors' offices, it's covered under Part B. And as you know, the FDA had a huge backlash to this, and it modified the indications and said only those people who were enrolled in a study could actually receive the drug, which hugely reduced the number of people who actually did receive it. How did it get approved? Well, a congressional inquiry called the approval process, quote, rife with irregularities, unquote. Now, you may also know that there's a new drug that's just out on the market, Leqembi, that does the same thing. There's actually a third drug that was that's in the pipeline that was written about in JAMA recently. And these drugs may be a little bit more effective and a little cheaper. So I'm a member of the Pharmacy and Therapeutics Committee for Regents Blue Cross, which makes formulary recommendations for numerous insurance companies. As a result of lobby efforts, the 2003 Medicare Modernization Act required that all drugs in all the categories that you see here must be on all Medicare formularies. So in our naivete in 2003, 2004, we wrote letters to the FDA saying, some of these drugs are hugely cost ineffective. Some of them are downright harmful, and they should not be used. Well, this was pointless. There is, in fact, a management implementation code that can be used to guide and prioritize more appropriate medications. Nevertheless, this was the impact of various interest groups on medical practice. When there's money to be made in business, people will find a way. And it turns out that buying medical practices can be very lucrative. So what this graph shows over a period of about a decade is the impact on the cost of a visit to the gastroenterologist in practices that have been bought by private equity firms versus those who have not. It started to diverge here where about 7 years ago, where private equity started to be involved. And you can see here that it rose in practices where they were not owned slowly over time. But by 2021, visiting a gastroenterologist in a private equity practice was a third more expensive. So if this makes you nervous about having private equity buy medical practices, how would you feel about seeing a physician in one of those practices? And you might also raise questions about the difference between for-profit hospitals and not-for-profit hospitals. So I'm going to give you just one more example. There are numerous treatments for arterial obstruction of the extremities. And there are partnerships between medical device companies and physician practices. From 2017 to 2021, about half of Medicare's atherectomy payments, and that totaled $1.4 billion, went to just 200 high-volume practices. So if you do the math, the median practice made $6 million on these patients. Now, the patient in this picture had 22 procedures by one physician, and she still lost her limb. So these kinds of events led Don Berwick to write a commentary in JAMA several months ago called Salve Lucrum, the Existential Threat of Greed in the US Healthcare System. Salve Lucrum means hello profit. He wrote, the grip of financial self-interest in US healthcare is becoming a stranglehold with dangerous and pervasive consequences. A few weeks after that, Tony Back wrote a letter to the editor and responded, what Dr. Berwick calls greed is celebrated in other circles as shareholder return. Meaningful change will require structural change. Now, I'm not an expert in healthcare policy, so what kind of structural change are we talking about? Well, on the plane coming here, I read about one, so I'll just read you part of a paragraph that might be a structural change. So in this commentary, the lack of a global budget for the US healthcare system has made it possible to deny the need for technology assessment and prioritization, despite the obvious truth that resources are finite, even in the United States. The rise of expensive treatments for highly prevalent conditions, such as Alzheimer's disease, we just talked about Aduhelm, and obesity, talking about Wegovy or Ozempic, among others, that could quickly swell public and private healthcare budgets, may finally force a reconsideration of this position, a new era in which the US healthcare reimbursement system explicitly considers cost, effectiveness, and distributional effects of paying for prescription drugs may have arrived. Or it may not, because the forces of business are quite powerful. So let me ask the question, what does it mean to be a professional in a corporate world? Well, since ancient times, altruism has been a fundamental tenet of the profession. This excerpt from the Hippocratic Oath, into whatever homes I go, I will enter them for the benefit of the sick, avoiding any voluntary act of impropriety or corruption, including the seduction of women or men, whether they are free men or slaves. I'm not going to comment on the social context there, but what I want to say is that the operative comment here is, into whatever homes I go, I will enter them for the benefit of the sick. So moving from ancient Greece to the Middle Ages, and I'm sure you could, an expert, Dr. Mutter is an expert on this history, he could make some comments on this, but moving from ancient Greece to Middle Ages, we see, for Western medicine at least, the emergence of all of the structures that still influence the development of medicine today, namely professionalism, regulation by the government, and capitalism. Now, these forces, which balance each other and have determined the character of the profession ever since guilds emerged in the Middle Ages, none of them actually requires altruism. All of them can be viewed as self-interested. Actually, I wonder if there's a fourth force that was left off of this, and I'm wondering if anybody wants to guess what that is. Is there another major influence on the development of medicine in this country? Well, I think it's religion. Religion was a very powerful force by the Middle Ages. It was ignored by government, incorporated by government, or acted as a counterforce to government, depending on whether there was wealth to be fought over. And I mentioned it for two reasons. One is that the ancient predecessor of the physician was the shaman, who undoubtedly had his or her own contract with society, in return for the professional service of taking the incubus of suffering onto themselves they were probably afforded some level of privilege within that society, such as, say, exemption from military service. But the other reason that I mention it is that religion is still a very potent force today, as we see in the culture wars over abortion. But government is where that tension between professionalism and religion is playing out now. Lest we scapegoat business or organizations outside of medical practice proper, I want to highlight some of the shortcomings from within our profession. So we have the Tuskegee study in which 4 Black men were intentionally infected with syphilis to study the natural history of that disease. I don't need to recount to you the horrors of Nazi experimentation during World War II. And in my opinion, the AMA has taken a number of problematic stances over time. Undoubtedly, racism was one of the motivations for refusing medical school admission to Black people. But there was also a financial interest as well. At the same time, they were working to marginalize other irregular practitioners, primarily homeopaths at the time. During the Great Depression, the Supreme Court convicted of the AMA of violating the Sherman Antitrust Act. For decades, the AMA fought against Medicare and Medicaid because obviously that would limit what physicians could charge the patient. And although the AMA does support the No Surprise Act, it's currently litigating the component of the that gives arbitration too much power, and also the presumption that the median in-network price is the appropriate out-of-network price. So the economist Milton Friedman and his wife Rose Friedman have claimed that the AMA actually acts as a guild and has attempted to increase physician wages and fees by influencing limitations on the supply of physicians and competition from non-physicians. So all these examples are artifacts of the social context in which they occur. It's what happens when we lose sight of our common humanity, which is why I chose for the title of this slide, comment by the Jew Shylock from The Merchant of Venice: "If you prick us, do we not bleed?" Do the right thing only works if it's internally incorporated. So where are the intersections of the profession and society? So I want to credit Schiffer Ginsburg for the notion that what's judged as professional or not depends on the culture in which we act. I'm going to explain this slide, which graphs the influences of professionalism and the influence on professionalism. So starting all the way over here at physician professionalism, we have things like, does the physician keep up with modern practice? How does the physician organize his physical practice? Obviously, that influences tremendously the nature of the patient-physician interaction. And conversely, those interactions influence professionalism by individual physicians. You only need to think of your own environment to realize how much these patient-physician interactions are influenced by the practice setting or by the training environment. And similarly, the training environment, practice settings influence these interactions. And all of these are nested inside things outside of medicine proper, the external environment, payment, policy, socioeconomic determinants of health. So what's considered professional depends on the context. It's less a matter of dichotomously deciding in black or white terms whether something is professional. It's really about thinking about what should the behavior be in the presence of conflicting professionalism values. And let me give you an example. Early in my own training, it was common to withhold a lethal diagnosis from a patient to spare them the pain. Right now, it's promoting patient autonomy is critical. So if what's judged as professional has changed over time, how can either one of those be correct? Even now in Italian, Jewish, or Japanese cultures, it may be appropriate to withhold a lethal diagnosis from a patient. So if it depends on where you practice, how can one be professional and one not be professional? Hence the importance of context. Now I want to move to organizational professionalism, and I'll define it simply as the idea that healthcare organizations have professionalism competencies and behaviors, just like individual professionals. Let's go over this graph, thinking about organizations. So intra-organizational professionalism might be things like, do we promote diversity? Do we tolerate unprofessional behaviors of one profession toward another profession? These kinds of decisions also influence how organizations interact with each other. Perhaps not so much, I think, in Charlottesville, but certainly in Portland, where I practice, organizations that are in competition with other organizations are influenced by these cultures. I also want to mention that we define, for the purposes of this paper, a healthcare organization is any entity that provides goods or services to patients or the healthcare system. So it includes things not only like healthcare systems, but things like the American Board of Internal Medicine, the American Medical Association, government agencies, community organizations, pharmaceutical companies. So these inter-organizational interactions are influenced hugely by the national healthcare environment. And collectively, I think they can influence the national healthcare environment. And again, all of these things are influenced by the external environment, payment policy, and the socioeconomic determinants of health. So I've already talked to you about the premise. The rationale is that medicine has become simply too complex to be adequately regulated by laws or by the professionalism of individuals. And taking care of patients has become too complex for the individual professional, requiring the expertise of multiple professions. Now, I want to say something about non-professionals, because non-professional healthcare workers are also indispensable to the function of the healthcare system. And I would challenge us to think beyond interprofessionalism, which is still othering. So if any of you are practicing physicians and have struggled in your clinic because of a dearth of medical assistants, or who have lost frontline workers to the immunization mandates, because at least in my health system, the non-professionals were much less persuaded by the science behind immunizations, then I would encourage you to consider the complex ecosystem of the entire organizational culture, not just professionals. So to remind healthcare systems of the reasons that they exist and to guide them in executing their social contract, a group of us developed the Charter on Professionalism for Healthcare Organizations. And this is an aspirational document. No single organization can embody all of the attributes or execute all of the commitments. It's based upon 4 principles. The patient comes first. So in making any decision about how to proceed, you can ask the question, does it benefit the patient? Second principle is everyone should have access to healthcare. The third is that the modern healthcare organization, it evolves. It's a learning healthcare system. And the fourth principle is that the model healthcare organization practices stewardship of resources. Now, all 4 of those principles are active in 4 different domains. So in the organization's relationship to patients, internally in the organizational culture, in relationships to the community, and in its operations and business practices. There were some controversies in the development of this charter. I just want to highlight a few of them. First one was, is healthcare a right? Well, we operated by consensus, and so you see that what we ended up with is access to healthcare. Everyone should have access. We argued a little bit about whether the charter should apply to only nonprofit health systems or to all health systems. Milton Friedman said that the only justifiable purpose of a corporation is to make a profit to benefit its shareholders. So the first publication that we made on organizational professionalism, we said that it only applied to nonprofit systems because we felt that this obligation to shareholders could trump professionalism. But when we got grants from a number of organizations to write the charter, which included the Federation of American Hospitals, the American Hospital Association, they encouraged us to think beyond that, to think about applying the charter to all healthcare organizations. And we'll talk a little bit more about that. We argued a lot about how much community benefit should a healthcare organization provide. Should it be 1% of revenue, 2%, 3%? We didn't specify because organizations vary in their richness, how rich they are. A little digression on these last two bullets. The Allina Health System is a large nonprofit system in Minnesota. The Attorney General of Minnesota is currently investigating the Allina system for its policy of refusing services to patients who have outstanding bills of more than $4,500. This was part of an investigation about how all health systems bill. And in Minnesota, all of the health systems are nonprofit, as they are in Oregon, and as I understand, they are in Virginia as well. When the Attorney General started to investigate, they stopped the practice. But he did say something that I thought was pretty interesting. Quote, "There's a growing consensus that there is very little difference between for-profit and non-profit hospital when it comes to behavior." And it turns out that Allina spends less than 0.5% of its revenue on charity care, and nationwide, the average is 2% for nonprofit hospitals. The charter it kind of stipulates a number of, so for healthcare systems that endorse the charter, you're making a number of commitments. I've put some of them on the slide here. The patient commitments are really nothing about me without me, that concept. It's about treating the patient as a whole person, not just the disease. Organizational culture, it's the responsibility of leadership to define what the culture is, to articulate the rationale for that, to model that culture. And in every healthcare organization, there are some outliers. There are people who don't treat other people professionally. We have a term called disruptive physician behavior. So it's leadership's responsibility to hold those people accountable. I believe that it's also the system's responsibility to provide remediation for those individuals, but ultimately to terminate them if they're unable or unwilling to uphold the culture of the organization. Burnout of medical staff is currently a crisis with the focus on production, the use of an electronic health system that was designed for billing and not for documentation. And post-COVID, healthcare systems are struggling financially. So that puts them in the position of often making decisions that erode rather than support well-being. And that can become a vicious circle, and it's really complicated, and I don't know the solution for it. But I do know that the focus so far has been on just physicians, but a culture is determined by all who are in it. If we're trying to create a healing environment for patients, it has to involve all the people that patient encounters. And most of the time, it's not the doctor, right? It's the food service worker, the janitors, the nurses. We have to focus on all of those folks. The commitments to the community recognize that only 10 to 20% of healthcare outcomes are determined by what happens in healthcare structure. Fully 30% of it is genetic, and roughly half of healthcare outcomes are determined by the social determinants of health. So the charter suggests that organizations should seek strategic alliances with other organizations that are compatible with their nature. And the strategic plan needs to incorporate community concerns, and that really necessitates having community members on the board of organizations. With regard to operations and business practices, it suggests that healthcare systems should adjust for the ability to pay. Medical debt is the highest cause of personal bankruptcy in this country. I want to say a few words about physicians forming unions. I've been very ambivalent about this for a long time, for a couple of reasons. One, it feels to me, why aren't physicians and their organizations, why don't they have a common interest in creating a culture that supports the well-being financially, health-wise, et cetera? But in thinking about this talk, I really understood what it was that bothers me the most about it, which is that it moves the motivators for our job from internal motivators, which is our calling, to external motivators. And I want to acknowledge that there are still things that we might unionize about that might help us promote our calling. But it still bothers me a little bit about how we view ourselves. What happens is that it comes down to money sometimes, that sometimes the healthcare organization's financial success is at odds with physicians' production expectations or their desires or the use of the electronic health record. Healthcare hospitals get reimbursed based on their patient experience scores. Where I work, physicians have told me that they're reluctant to not provide a prescription to a patient who requests an opioid because they're afraid of what that's going to do to their patient experience scores. I was surprised to actually hear this from more than one person. We've always had this tension whether we prescribe antibiotics for sore throats, et cetera. I mean, there's always been a bit of a tension there. But this focus on the patient experience score is problematic. And similarly for nurses, it's a big expense, whether your nurse ratio is 4-to-1 or 3-to-1, but it also depends on patient safety. I want to briefly make a business case for investing in clinician well-being. So burnout doubles turnover. Burned out physicians leave twice as much as non-burned out physicians. The replacement cost for a physician is 2 to 3 times their salary. The recruitment costs are only about $88,000 in hard costs, but the lost revenue is 2 to 3 times that, depending upon what your specialty is, $500,000 to $1 million. And there are a lot of indirect costs. When one person is burned out and they start talking about it, other people get burned out too. Burned out physicians have increased medical errors, they have increased malpractice suits, and decreased patient satisfaction. And this ignores a whole series of considerations that applies to academic medical centers like your own. So the forces that threaten professionalism, I'm not going to go through all these. I want to pick a couple of them. For the individual, I think medical debt is a threat to professionalism because it incentivizes learners to go into specialties that are not necessarily in society's best interest. Primary care, geriatric. Moving to organizations, the competition between healthcare organizations and current law can be problematic. So where I practice, there are maybe 4 different health systems. You know, if the legacy health system says to Providence, you know, this community doesn't need 2 children's hospitals, it doesn't need 2 cancer centers, 2 cardiovascular centers. Why don't you take Children's Hospital? We'll take cardiovascular centers. Can't do that. That's absolutely illegal to do something like that. I'm going to skip the rest of those. I also want to ask the question, does business have a social contract? Even though what I just said about Milton Friedman and the obligation to profit. If you substitute the word customer for patient, might the charter not apply to businesses as well? Could there be a charter on healthcare organizations? So there's a spectrum in regard to the relationship of businesses to the customer. You see on one end of the spectrum, the customer is always right. You see on the other end of the spectrum, caveat emptor, let the buyer beware. With regard to the domain of organizational cultures, you have organizations such as Google, who provide numerous perks to the folks who they're cutting back on them because, financial hardship times. But then on the other end of the spectrum, you have Amazon warehouse employees and their exploitation. But I do want to give you some examples of social responsibility by business. So in 2019, the Business Roundtable, which is an esteemed group, the statement of a purpose of a corporation, it made a commitment to all stakeholders. We commit to deliver value to all of them for the future success of our companies, our communities, and our country. Larry Fink, who is the CEO of BlackRock, says, we focus on sustainability not because we're environmentalists, but because we're capitalists and fiduciaries to our clients. Make no mistake, the fair pursuit of profit is still what animates markets. But what he's doing is he's making a business case for social obligations on the part of business. And we've seen numerous categories of environmental and social and governance evaluations of business companies. And we've seen the emergence of B corporations, which I only recently learned about. B corporations are businesses that meet the highest standards of verified social and environmental performance, public transparency, and legal accountability to balance their profit and their purpose. So I want to come back to the role of government because medical professionalism and presuming a social conscience by business is going to be insufficient. So Frances Haugen, who is the whistleblower of the Facebook internal documents, states that's what government is intended to do in democratic capitalism, to use the law to steer the market back into alignment with the public interest. And to return to the charter, at least in medicine, that's what it was designed to do, to align healthcare organizations with the public interest. Here's an example about how governments can do that. The Inflation Reduction Act. Medicare can directly negotiate with drug manufacturers. You may have seen that they've just rolled out the first 10 drugs that they're going to be negotiating with. Drug companies that raise their drug prices faster than the rate of inflation have to pay Medicare a rebate. And starting in 2025, there'll be a $2,000 cap on out-of-pocket Medicare prescription drug costs. So when you see the scope of all these things that are involved with professionalism, it can be daunting, and a sense of individual futility is certainly understandable. And by the way, you can view the charter itself as an appendix to our publication. It's one on your invitation to this session. You can read it in detail. But I want to come back to what do we have control over? So what we do have complete control over is professionalism. What we have no control over is regulation, or minimal in lobbying. And in business, we have some control and can negotiate. So these are those three forces again. And solving social problems will require cooperation among these three. The social determinants of health are beyond the purview of government, beyond the purview of healthcare systems, and also of communities. They're going to have to collaborate. So doing our part as healthcare organizations and having professional relationships with our staff, with our communities, with other agencies, as well as with our staff, is not only the key to restoring faith in medical profession, but also in fulfilling our social contract. So thank you very much for listening to this. Appreciate it. This is a list of organizations that have endorsed the charter. We would be pleased to have UVA join us.
Thank you so much, Dr. Egener. that was really inspiring, and I feel like you covered so much ground. This is, and really thoughtfully too, I might add. Since the Brodie Medical Education Fund Committee is interested in medical education, I wonder if I could kind of bring this back around. I'm convinced that we need organizational professionalism. What's our role as a school of medicine and as a program that trains doctors to advance this cause?
Well, that's a great question. So I've been here for a day and a half, and I've been exposed to a number of learners. And the first piece I want to say they come here with, which is the relationships with the patient. They come here inspired. And I don't think you have to do anything but take advantage of that. In the domain of culture, if you want them to be in practices that promote the health of the patient and the people that they work with, I think sometimes the culture that our learners are in ignore some important parts of their well-being. And as we've talked about a little bit already, empathy declines in medical training. Why does that happen? Well, it has to do with the climate that learners are in. And so I think we need to do something about that. With regard to, I don't know if you want to spend educational time on operations and business practices. Some people are saying, I don't know how to start a business, so I need to learn that in residency. But I do think there's some exposure to a diverse community would be useful as well. So I think you can be guided a little bit by the domains of the charter in that sense.
Are there questions from either the in-person audience or the virtual audience?
Yeah.
Thanks for joining us, Dr. Egener. My name's Andy. You mentioned about how in the state of Minnesota, Oregon, Virginia, that all the healthcare systems are for nonprofit, but there are private for-profit health insurance companies like United Healthcare, which is based in Minnesota. UHI is the largest component of the stock market. And then you mentioned the social contract and the business contract. So the question is, do you think these private health insurance companies are doing just enough so that they don't get banned by Congress in terms of denying or accepting, coverage of certain events? Or, what's to stop United Healthcare from saying, we want to save our shareholders $3 million today. So today, September 21st, we're going to have no CT scan reimbursements. What's to stop them from doing that?
You're absolutely right. And I want to come back to an earlier part of your statement at first, in a second. But I think that's the role of regulation. I think that's the role of government, because they're not going to be looking at what's necessarily the best for the patient. I also want to say that insofar as those nonprofit entities go, those nonprofit hospitals, it may feel like the hospital that you're in is a for-profit hospital, even if it's a nonprofit hospital. I've only practiced in nonprofit hospitals, but I'm told no margin, no mission, which is an excuse for all kinds of exploitation, in my mind, of the people who are working there. So I think a couple of things. One, but to answer your question directly, I think it's not going to be, you can't leave it up to them. I think you need to have government regulation. You can have you can have, I don't know whether businesses would endorse the charter. I do see you saw the list of nonprofit organizations that endorse the charter.
Dr. Egener, there's a question in the chat from Brandon Lopez, who asks, where can we learn more about organizational professionalism and the ties it has to medicine?
Well, we only have 2 publications on it. There's not a lot out there. But I think we're growing. We'd like to grow the network of organizations. I think you don't necessarily need to learn a lot about it. I think you can act on it based upon the principles that we have so far. One of the things that we actually are engaged in research now, saying, so how do healthcare organizations define professionalism? And what are their definitions? And we'd like to do that's a pilot study, and we would like to do a much more cross-sectional study of for-profit, non-profit hospitals, academic, non-academic centers, community-based training programs, academic training programs, to get a sense of what they're doing. But there's not a lot out there right now, sorry.
I think you mentioned that there are some links in the invitation to this medical center hour, and that would be a resource for people as well.
Right. So the one is to the article on the Charter for Health on Professionalism for Healthcare, and then there's an earlier paper which kind of laid out some of the principles in 2014, I believe, and then the other links are the Don Berwick's commentary, and then Tony Back's retort. Yeah.
Dr. Mutter?
So I have a question, and thank you again for this great exploration and setting us all on a journey toward organizational professionalism. And I think one question I have, and a lot of this comes from some really wonderful conversations that we've had in our center over the years from some of the courses that we teach about what professionalism means to our students as they're getting ready to graduate. And it strikes me that organizational professionalism as a concept is also a skill. And one of the things we hear from students and trainees a lot is professionalism is also about competency. It's also about having a certain skill set. And when I think about the graphs that you had up, inevitably I was like, wow, that's a lot, right? That's a lot to master. Achieving mastery of organizational professionalism is challenging. And so is there a way in which we need to intersect the concept of organizational professionalism with individual professionalism, that we as individuals, as we think about our own professional journeys in healthcare, whether we're clinicians, or I would add, whether we're on the business or management side of things in healthcare institutions, do we need to think about organizational professionalism as an individual professionalism skill that we need to work toward mastery, so that when we are making decisions on behalf of our patients, on behalf of an institution, whatever it might be, that we have that skill set to bring to bear?
Yeah, great question. And that first paper that I didn't spend a lot of time on actually goes into the competencies. So they're actually listed there. It starts with kind of, from the scratch, the ancient Greek values and moving along. But the answer is there are ways that we can, as individuals, do that. And I think we might not be in a leadership position of an organization to do it directly, but we have advocacy that we can do as individuals, whether, if we're just simply a practicing physician or a student, we can act on some of those domains. But then if we are in a leadership position, how do we influence the organization that we're in? Or even if we're not in a leadership position, how do we, what's our role in getting our organization to think this way, right? And people can take that on as an individual professionalism competency, the degree to which they promote the organization in which they are in to execute those commitments.
Yeah, hi. So I guess kind of this is along a similar line, but I know as you're talking, you kind of mentioned that you weren't always in favor of things like unionization or stuff like that. But I guess how, as an individual practitioner or as a student or a trainee or someone like that, how would you affect change then if you feel like your organization's practices are not in line with good organizational professionalism? Like what what would you think is the appropriate way of going about doing that, especially if you think like unionization is not the right answer?
Yeah. And I'm ambivalent because I do realize that there's power in that organization and many people speaking with, multiple people speaking with a single voice. So I come back to my slide about boundaries, and I think this is so important in medicine, in our relationships with patients. What are we willing to accept as individuals, even in an organization? So we have the power to say, we don't have the power to say to the organization, this is what you have to do for my salary, for my staffing ratio, where as an individual, we can't do that. What we can do is to choose whether we are willing to participate in that and say that to the organization. But it is more powerful if multiple people do that. And so the extent of burnout, which affects 50% of physicians, for example, I mean, that's a problem for healthcare organizations. And they recognize that at a time when they're trying to recruit more physicians. How do they recruit them into an environment where 50% of them are burned out? So I remain ambivalent. I think I recognize the bargaining power of a larger voice, but I worry about also the erosion of the professionalism by making myself simply an employee rather than someone with a calling.
We're running short on time. I just want to acknowledge one more question that's in the chat about the role of media in influencing the public's view of professionalism.
Well, that's a great question. And I haven't thought a lot about that, but yeah, so the media. So I think the, social media, which, the younger of us are much more technically adept in, can be useful. And then you get into what about, and there's a huge debate currently now about the media and what's permitted. So I think about misinformation about COVID vaccinations, for example, and the influence that that has on how people evaluate the professionalism of physicians. Right, this had a huge impact on us. You're out of time, so I'm not going to tell you that story. But I think that maybe there's even a government role in, and that's the First Amendment issues are going to be playing out in that regard. It's a great question, great domain to explore.
Well, thank you. Unfortunately, we are out of time, but I want to thank both of you. Thank you, Dr. Egener, for making the trip here and for really, again, leading us on a great journey that I'm sure, as we always say in the Medical Center Hour, we will keep talking about many of these things within our own networks after this hour that we've shared together. Please join us for our next Medical Center Hour, which is on October 4th in 2 weeks. That will be Zoom only event as our keynote celebrating National Primary Care Week here at UVA and beyond. We will have Dr. Amelia DeMarcus, who is a professor and researcher in the Department of Family and Community Medicine at UCSF. She will speak to us on the integration of primary care and social care, very pertinent to today's topic as well. And so thank you again to everyone. Thanks to our audience, and we will see you in a couple of weeks.